Hi, everyone. My name is Chris Ding. I'm one of the PGY4s for those of you who don't know me. I'm the guy who's constantly emailing you about sim stuff. So today I'm going to be talking about quote unquote pimping in medical education as part of the wellness lecture series. So first off, I'd like to thank the wellness lecture series committee, which consists of Dr. Wolfram, Dr. Stetz, Dr. Camacho, and Dr. Green. So for today, I'm going to be talking about the definition and history of pimping in medical education, its impact and relationship to wellness, and steps we can possibly take to hopefully develop a more wellness-centered approach to learning and teaching. So obviously, pimping is a slang term, so there's not necessarily an official definition, but I think a lot of us have a sense of what it is from our own experiences with it. It usually involves rapid fire questioning, usually from an attending to a resident or a resident to a student. It's usually done in a public manner with a lot of other trainees like residents and students around, and possibly in front of patients even. It's usually done to evaluate someone's medical knowledge and to hopefully facilitate teaching. As we all know, it can also have some toxic elements as well. So sometimes the questions are made to be unanswerable or at least very difficult. And in really extreme cases, it can actually be done with the intent to humiliate. So the first formal writing on pimping in medical education was this paper called The Art of Pimping, which is published in JAMA, actually, in 1989 by Dr. Frank Brancotti. And he kind of went through the background of pimping and like what it's used for. He states that pimping, though the terminology comes from the German word Pumpfrage, which basically means to pump questions at someone. It kind of reminded me of the fire hydrant comparison a lot of people make to medical school learning. He also cites William Harvey, which you see on your left, and Abraham Flexner on the right as using the term in their writings on medical education and how they teach their students. So Dr. Brancotti says that on the surface, the aim of pimping appears to be Socratic instruction. The deeper motivation, however, is political. Proper pimping inculcates the intern with a profound and abiding respect for his attending physician while ridding the intern of needless self-esteem. So in short, the practice, at least at the time, was to really reinforce the medical hierarchy. He also kind of gave recommendations to attendings on what they should pimp people on. So for instance, arcane points of history, such as who performed the first lumbar puncture or how the word syphilis was come up with. Teleology and metaphysics, which I had no idea what that was. It's basically questions that medieval philosophers would delve into, like why are there two kidneys and why are they paired? Exceedingly broad questions like what are all the causes of a fever? So one that you can never really completely answer. And then two, I think that we are probably more familiar with, eponyms. People love asking about that. And then technical points of laboratory research. So someone asking about their own laboratory research that you most likely have not read about. So about 20 years later, in 2009, Dr. Detsky, who is a Canadian physician, published a similar article also called The Art of Pimping, also in JAMA, as kind of an update to the original one. He says that the unspoken truth is that these teaching points reinforce the pecking order from student to intern to resident to staff. However, a more modern perspective is that the purpose of pimping is to increase retention of the key teaching points by being provocative. So you see a little bit of a change in attitude toward it as like, oh, maybe there's some educational value to this. So he also gives some advice to attendings. The first thing he says is respect educational order. So he basically says that you should never ask a medical student to try to answer a question that a resident already answered incorrectly, because if the medical student answers it correctly, it makes the resident look pretty bad. He also says, use opportunities to comfortably draw people into the conversation and find an opportunity to provide praise. So as you can see, a lot of these are actually pretty nice things to advise attendings to do, I would say. He also gives advice to students about how they should react when they are pimped. So a lot of these are kind of straightforward, like avoidance, being a politician and avoiding an answer. There's also pimping back the attending, which seems a little risky. There's one that I wanted to clarify called muffin eating, which is actually more literal. And he's basically saying that you should carry a muffin in your white coat at all times. And when an attending starts pimping, take out the muffin and start eating it, because he'll be less likely to call on you. And if he does call on you, just pretend that you're choking on the muffin and run away to the nearest water fountain. So there's that. So I started medical school in 2014, about 5 years after the last Art of Pimping publication. And for the most part during my 4 years, I don't think I ever encountered pimping that was meant to humiliate or to harass me or anyone else. I think a lot of attendings use it as a way to kind of start a conversation, get a sense of where your knowledge was, and try to expand on that knowledge. That said, there were some aspects of it that I still found really frustrating. So I often found like the questions that were asked were very much in isolation and not really having much clinical experience. It was hard to know how I was going to use that information, the context of that information. So even if it was meant to be educational, it sometimes felt like just kind of pointless. The other part of it that was, I think, hard to deal with was that, pimping is obviously used in evaluations of medical students in terms of like their medical knowledge. And that can create a really high pressure situation, and didn't always feel like it was a fair assessment of my knowledge. So in response to this, I developed what I think was like a really high stress but can-do attitude, and really tried to be organized and regimented in my studying. So every night going through a certain number of textbook pages, doing a certain number of UWorld questions, and going through a certain number of flashcards. And I think it made me feel really productive and like I was doing something. But in the long run, I'm not really sure if it really helped my learning that much, because I was just kind of more going through the motions. So kind of in the middle of my medical school experience, this paper came out in Nature, which basically looked at the relationship between learning and stress. It kind of reviewed a bunch of different papers that were written over the course of several decades. It basically concluded that stress can enhance the formation of new memories. I think we all have moments on shift or from other parts of the hospital that we will definitely remember for the rest of our lives, for better or for worse. But obviously stress can also have negative impacts on learning. So it can actually impair your ability to recall past events. And it also makes you less likely to be flexible and change your views in light of contradictory information. And then long-term stress can actually reduce the size of the hippocampus. So if you are really stressed out about learning, then it's just counterproductive and you'll be dumber in the long term. So I, continued this really high stress method of studying kind of well into my residency years. And it was really only toward the end of second year that I kind of maybe changed it. One really informative event I had was a shift with the beloved Dr. Hoxton.
Hold on, Dan.
I was taking care of a suicidal patient who had told me that he lost his antidepressant medications. And Dr. Hoxton got really irate with me because I didn't ask how or why he lost those medications. He told me this: If you want to do this whole doctor thing, you should probably try to be curious once in a while, like hello, in his classic Hochstein way. So apart from being a little taken aback at first, I actually really appreciated what he said, because he used a word that I hadn't really thought about in a long time, and that was the word curious. Because I went back and I was thinking, I don't really do things to be curious. As an ER doc, or in my conception of myself as an ER doc, I was like, I ask very pointed questions, I get to the point, I do what I need to do, and then I move on, right? So, there wasn't really any room for curiosity in this kind of world of mine. But I got to, started to think, what am I really curious about? And it's something that I, at that point, hadn't really truly asked myself in a number of years. And it made me realize that, as a medical trainee, there are a lot of incentives for learning and disincentives for, not learning and being lazy. So, you want to get good scores to get into a good residency. You want to look good in front of your peers and attendings. Once you're in residency, you want to try to avoid having to go to board review. And then obviously, you want to take good care of patients, not harm anyone, don't get involved in a lawsuit. And while honestly, these are all really good things to worry about, they're all external factors if you think about it. They aren't really what drives us internally to learn and to really live the life of a lifelong learner that we as physicians really are supposed to be learning or doing. And so, I started to think about what I'm curious outside of, purely emergency medicine. I realized I was learning in learning itself. How do I learn? How do others learn? How do I make learning a better experience? So I've gotten more involved in simulation. As an undergrad, I was exposed to 3D printing, and at the beginning of my third year here, our department acquired a 3D printer, so I unexpectedly got the opportunity to pursue that interest as well. And then I'm not even really sure if this is relevant to anything, but I am really obsessed with the British cooking star, Nigella Lawson, who I think is fabulous and whose food and writing is a gift to the world. But you can ask me more about that later. With regard to medicine and curiosity, I realized that, yes, my study habits were a little much, but I still used questions, particularly Roche review, but I kind of changed my technique. So instead of just going through the questions and just reading through the explanations, I really tried to analyze the questions and think about what this particular question raised for me. Like, what am I curious about? What should I research more? What do I need to hone in on? And so in my third year of residency, I completed a really pathetically low number of questions, like maybe 10% of the entire Q bank before the test. And I felt really bad about myself because oh gosh, I spent all this money or CIR money. But it actually turned out that I did the best I had ever done on the in-service exam. And so from that experience, I kind of realized that, I can chill out a little. I don't have to do 50 questions in a certain period or whatever. And then I realized during the course of my residency that I had, just kind of naturally become interested in certain things that I wasn't necessarily interested in as a student. So dosing, for instance, as a student, it's just really boring numbers on a page or on a table that you're supposed to memorize. But once you get some clinical experience, you realize how those numbers can be really important. So my first CCT shift as a senior, my first ever code was actually a 24-year-old female who just collapsed in the middle of the pod and arrested. And I remember very specifically, in a young female, you always think about PE. And I didn't know the dose of TPA for cardiac arrest off the top of my head. And luckily, Dr. Morales was able to teach me, and now I really remember. So a lot of famous people, aside from Dr. Hochstein, are also fans of curiosity. So Albert Einstein says one cannot help but be in awe when he contemplates the mystery of eternity, of life, of the marvelous structure of reality. It is enough if one tries merely to comprehend a little of this mystery every day. So I think as physicians, we are really privileged to not only study the human experience just in books, but really get to witness it up close every day, especially in the emergency room, more so than other specialties, I think. Another physicist, Richard Feynman, said, "Study hard what interests you the most in the most undisciplined, irreverent, and original manner possible." And so this is in direct opposition to what Dr. Brancati said about pimping, where it was used to enforce a medical hierarchy. I think when we pursue our curiosity and our passions, it's really an expression of who we are as individuals. And lastly, T.H. White, who is a British author, wrote that the best thing for being sad is to learn something. That's the only thing that never fails. So I think that, we have all had or eventually will have patients that we look back on and think, oh, like maybe I should have done something differently or could have done something better. And sometimes really the most positive thing that you can take away from those experiences is to learn from it and to do better the next time. So apart from quotes, there are actually quite a number of psychological studies that look at the relationship between curiosity and overall well-being and life satisfaction. And I definitely don't have the expertise to analyze these psychological studies, but suffice it to say that there is definitely a positive correlation. And then for us specifically as healthcare providers, curiosity can also be a pathway to increasing our empathy. So Jody Halpern, who is a professor of bioethics at UC Berkeley, she writes, caregivers who can learn to sustain their genuine curiosity about and receptivity to patients' perspectives, even in the midst of emotionally charged interactions, not only reduce levels of anger and frustration for both parties, but they can significantly improve decision-making on both ends and increase the effectiveness of treatment. So, this is something that I've tried to implement with varying levels of success. And I think, like when you get into a conversation with a patient that you don't necessarily agree with, sometimes if you think about, why they have those thoughts and like what environment they're in that such a thought could exist, is actually pretty interesting and will make you a little bit less frustrated. So this is all well and good, but as you know, we practice in the emergency room like this, where everything is kind of chaotic and very high stress. So it can be really hard to imagine yourself taking a step back and just pondering, your environment, the world, the universe, whatever. But I think there are some things that we can do in our small moments of respite that can, really improve, tap into our curiosity. So with each other, we can think about, for a certain patient, did we miss anything? What could we have done better? This is kind of the goal of debriefing that we do in CCT and other critical situations. And you really tap into the curiosity and the perspectives of all of those around you. For our students that we, try to teach, I think one thing we could do at the end of each shift is ask, what is one most burning question that you have about your shift today? And it kind of makes them think about their own questions and what they're curious about. And even if you don't have the answer to their particular question, it makes them think and hopefully inspires them to learn on their own. And then lastly, with our patients. So the next time you have a patient who wants to leave AMA to feed their dog, you can ask, what kind of dog do you have and what's the name? I think when we try to get to know our patients and their lives, they're more likely to open up and be receptive to our advice. So I want to end by kind of going over the most modern and updated view on pimping in medical education. This paper was published by Dr. Chen and Dr. Priest at Oregon Health and Sciences. So they raised a number of of good arguments, I think, against pimping. So one is that, the prior attributions of the term to William Flexner and William Harvey and Abraham Flexner, they say were actually false and completely made up, that they never actually used these, and the authors before just kind of fabricated it. And also Pumpfrage is not a German word that actually exists. Germans don't know that word, including Dr. Wolfram, who told me that it's not a thing. They also point out that pimping obviously has very sexist undertones. And that is especially problematic in our profession that does have an unfortunate history of sexism and discrimination against sexual minorities, both in terms of patients and colleagues. And obviously that can be a big problem for us. They also point out that, tying this practice of pimping to Socrates is really kind of tenuous. As you know, Socrates was a Greek philosopher, and he was really considering really broad questions where, your particular answer didn't really matter, but he wanted you to, by constantly questioning you, wanted you to develop your justification for those beliefs. Obviously, especially in the early part of medical education, your answer does matter, and you obviously should strive to be correct. And it's kind of a very different learning goal and environment. And lastly, they point out that pimping is sometimes, it's just like the most easily available tool for teaching. It doesn't really require that much training, but really like true education and teaching is a separate art and discipline in itself. And that we as doctors, should appreciate that fact and really try to become teachers or better teachers in its own right. So to summarize, pimping was born of the need to enforce medical hierarchy by humiliating trainees initially. Later on, it was shifted to be more educational, but it remains problematic both as a pedagogical tool and as a term in itself. And then lastly, always stay curious. Thank you.